Good morning, Minister. Thank you for joining me today. I hope that my suggestions before you this morning will be both insightful and informative as to the lived experiences of Bame communities, both during the pandemic and as we transition to COVID recovery. It is important to reiterate that COVID is not a socially neutral disease. It exacerbates long-standing structural inequality within the UK. As Aola Solanke succinctly puts, there are two viruses affecting people from Black and minority ethnic communities across the UK. One is COVID-19 and the other is discrimination. This understanding is crucial to the underpinning policy change and positive, impactful improvement. So, what does the evidence show? Firstly, to understand the overrepresentation of BAME individuals, it is crucial to note that Black, Asian, minority ethnic groups make up 14% of the UK population. Since the beginning of the pandemic, the overrepresentation of BAME individuals in COVID statistics is subsequent negative impact has become clear. Public Health England's analysis concluded that individuals from BAME background had between 10 and 50% higher risk of death when compared to white British individuals. The intensive care national audit found that 34% of COVID patients were of BAME ethnicity, demonstrating a huge overrepresentation from the 14% of the population who these communities make up. Further concern lies within NHS statistics. Public Health England identified overrepresentation of death in healthcare workers. Not only were the first 10 healthcare workers to die from COVID all of BAME background, 63% of healthcare worker deaths could be attributed to this group. Not only does published research evidence the highly disproportionate health impacts upon BAME communities, it also demonstrates the disparity in financial hardship experienced. In summer 2021, Barrack et al. Noted disproportionate decrease in earnings across the population. The average earning for BAME workers dropped by roughly 14% during the pandemic, whilst for white workers this was only 5%. More so, the Office for National Statistics noted that the number of individuals in employment dropped 26 times more than it dropped for white workers at the same period. The seismic impact of COVID-19 and the pandemic upon BAME communities is evident. However, it is far too reductionist to view these as isolated issues. Key to understanding this disparity is the social science understanding of structural inequality. I propose to you that COVID-19 is a syndemic. First used by Merrill Singer, a syndemic is a set interconnected issues of which significantly affect the overall health status of a certain population. A wealth of literature and publicised evidence demonstrates historic prevalence of inequality within the UK in relation to ethnicity. The pandemic has simply shone a light on this equality and multiplied its effect. The inequalities of BAME groups pose a domino effect, threatening their health and subsequently their contraction and risk of COVID-19. Disadvantage at one level perpetuates disadvantage at all levels. This should remain at the forefront of society's mind in tackling these issues. Firstly, I bring you to health inequality. Public Health England note that biological determinants for health inequalities in COVID infection and death can be seen. Comorbidities such as obesity, cardiovascular disease, and diabetes are more common within BAME communities. Recently, University of Oxford found the risk gene is 3 times more prevalent in South Asian populations as it is in white populations. However, the Royal College of Nursing highlighted that biology alone cannot provide a true understanding, to which supports my notion that the COVID-19 is a syndemic. Pre-pandemic, the Marmot Review highlighted health inequality as extremely prevalent within the UK. This included differentiation in healthcare access, provision and advice of medicine, and admission to hospital. This too is prevalent throughout the pandemic, if not increased. The Lawrence Report notes barriers to healthcare that BAME communities faced, including language and cultural barriers and inherent unconscious bias. The government's research project highlighted that alongside poor access, BAME communities reported poor past experience in care and treatment. Public Health England noticed this has produced a reluctancy for minority ethnic communities to seek care on a timely basis and therefore may explain some of the COVID statistics. This was also caught by widespread media, whereby a distrust in the NHS did occur and was well reported. The Office for National Statistics reported that vaccine hesitancy is also more common in BAME groups, Perhaps again, this is compounded by the distrust in the NHS and healthcare provision. Secondly, I bring you to occupation. Occupation is a structural determinant of health in vulnerable populations. Alongside its dominant impact on housing, lifestyle, education, crime, and financial security, BAME workers are overrepresented as key worker populations, shutdown sectors, and insecure, precarious work. This poses twofold susceptibility to COVID issues. Those who are working are vastly more exposed to catching the virus than those who could not work from home, often face unemployment, providing explanation as to both health and economic disparities. Firstly, I'll address those who could work. BAME groups are more likely to work in occupations of higher risk of COVID exposure, including health and social care, cleaning, public transport, and retail. During the height of pandemic, these groups were overexposed. Working on the front line may have attributed to general increased infection rates. However, the death rates of BAME NHS staff was highly increased from that of their white counterparts. Inequality in the workforce is clearly evidenced. For example, the British Medical Association found that in April that 64% of BAME doctors had felt pressure to work in settings with inadequate PPE, compared to only 33% of white doctors. However, the distrust in the NHS, as noted above, may have fed into a reluctance for staff to challenge this. On the other hand, there is also an overrepresentation of BAME workers in low-paid and precarious jobs. For example, UCL revealed that BAME millennials are 47% more likely to be on zero-hour contracts. Statutory sick pay is only £95.85 per week. Even this is not offered to those on zero-hour contracts at all. Occupation directly intertwines into financial hardship with BAME communities, to which I bring you on to now. As noted previously, the pandemic induced a huge loss of earnings for BAME workers. The Institute of Fiscal Studies noted that BAME workers made up 15% of workers in shutdown sectors, compared to 12% of all workers. The Runnymede Trust found that nearly 1 in 3 Bangladeshi men worked in catering and 1 in 7 in taxi driving. These areas of employment less susceptible to job insecurity and loss of earnings as a result of lockdown, whereas white workers are often able to comfortably work from home or were furloughed during the job retention scheme. Finally, the 2008 recession exposed BAME communities to great financial loss and austerity, meaning that many families have little or no savings. Bangladeshi and Black African households only have 10p for every £1 in savings held by white British households, meaning that they are more likely to expect difficulty paying their bills in the upcoming months. As we are now moving out of pandemic into recovery, there is a massive BAME communities who may be unable to recover due to this job loss and financial hardship experienced over the past few years. This is where I bring you on to my potential policy responses. As you can see, Minister, there is a clear need for systemic and long-term solutions as we transition from COVID in a way which promotes equality and rebuilds the harsh disproportionate impacts which it's had on BAME communities. The policies I put forth today are underpinned by both long-term and short-term preventions, not only tackling inequality, but ensuring individuals are given the support they need. Firstly, I bring you to the introduction of wealth tax. In a period of COVID recovery, the UK is in an economic crisis. The National Institute of Economic and Social Research recently forecasted recession in the second half of this year. We are currently in a period of a huge rise in the cost of inflation, cost of living, financial debt, and a tight labour market. Having identified that BAME communities have suffered severe financial hardship, we look to COVID recovery as something where we need to support these people through seemingly tough times yet to come. Tax needs to once again become a revenue generation tool. Many have called for the implementation of progressive wealth tax based upon asset value minus debt. This occurred during World War II. During the pandemic, the wealth of globe's billionaires grew by $1.9 trillion. In 2020, the International Monetary Fund called for wealth tax to boost the economy, making money become available to expand public services, enhance safety nets, and meet the UN Sustainable Development Goals. Andrews et al. View that wealth tax could be used as an equalising and empowering tool, where private funds should support the public. This wealth tax would accrue an active state and accountability to be held, whereby private money could be pumped into the provision of welfare, healthcare, education opportunities. This would have a domino impact on BAME communities, both improving their current life chances, but also allowing them to be in a better position should COVID worsen again. BAME individuals are vulnerable, as identified, with often a lack of savings to support themselves, their businesses, and their family. Any economic boost and provision of welfare service would have a direct positive impact to bridge the inequality gap. However, Minister, I of course note that taxation goes against the current government's policies and manifesto. It is unlikely that the House will agree to such a policy. Therefore, I bring you to Policy 2, a new race equality scheme. The Lawrence Report highlights the long-term need to end structural racism. As identified throughout this presentation, there is a clear and persistent structural racism. The UK by law is committed to tackle this under the Race Relations Amendment Act 2000. Despite this massive evidence, to which you can review within my bibliography, there is a lack of government action. The Equality and Human Rights Commission calls for the development of a new transformative race equality strategy to promote accountability of government and to create understanding of lived experiences. Regular race audits should be publicised by all government departments and bodies to ensure recruitment, progression, and inclusivity of BAME individuals. The British Medical Association notes that data is absolutely crucial. Unless we have the data, we just don't know what we can do. Whilst government has created ethnicity facts and figures service, there are significant gaps in recording which need to be bridged, to which I propose this should be at the forefront of this strategy. This policy recommendation would require building trust with communities. A localised approach would be absolutely necessary, whereby government promote BAME individuals to influential and leadership roles, ensuring that the lived experiences of BAME communities are expressed at every step of research, planning and strategisation. Also, that the local councils work with local communities to become educated on these said experiences. The efficacy of local government response was noted during the pandemic. Therefore, I propose this should be put forward in its recovery too. Finally, education and curriculum change is absolutely necessary to improve racial equality. Biases are learnt behaviour, so if we can tackle these at the root in children and ensure education of inclusivity and promoting integration, it will certainly improve outcomes. Finally, BLM movement not only confirmed that change is necessary, but this began for the re-education and mass spreading of awareness throughout society. This should be underpinned with clear milestones and parliamentary accountability for success which has not yet been seen in this area. Finally, I bring you on to tackling health inequality. Dr. Owen Williams draws upon the urgent need for the NHS to address health inequality. Since the Marmot Review in 2010, little has been done to remedy this issue, meaning that once the pandemic hit, it was too late, and unfortunately these inequalities were magnified tenfold. The NHS were committed to such equality, however stakeholders called for a strengthened response. We know that NHS service users from BAME communities felt they had received a poorer standard of care due to their ethnicity. However, the implementation of a trusted people and places strategy allows NHS staff to work with and listen to these experiences in a localised approach, hopefully restoring the trust that has now been lost. Williams notes the importance of mirroring the percentage of BAME individuals within the workforce as in the predominantly white leadership at current. The promotion of BAME workers will promote a bottom-up approach, whereby representation and inclusivity is guaranteed. This should also include the education of white NHS workers as to how inequalities can be identified and prevented. It is these BAME individuals who are well informed to make such educational change. Furthermore, effective and appropriate ethnicity data, as mentioned before, needs to be published and collected. Identifying patterns between populations, subsects, and areas, Public Health England argue that a tailored approach can be reached to healthcare. This will allow communities to adapt accordingly to the specific health needs of BAME communities in the area and conduct further research into specific comorbidities. This regaining of trust should also be utilised to educate and promote the vaccination, which has now been proved to minimise COVID risk. Therefore, Minister, while I see great financial benefit to BAME communities in Policy 1, I also understand its viability is questionable. More so, while I believe that race equality scheme is both overdue and essential, the impacts of such long-term rather than protection can be seen here. We need both of these things to occur. Therefore, I suggest that focus on tackling health inequality with the implementation of specific policy recommendations, as mentioned on the previous slide, is something that we do need. Not only will this address the shocking disparate treatment of BAME minorities within healthcare provision, but BAME communities will be able to regain trust which has been lost in the NHS, promoting accessibility to healthcare resources and vaccinations. This provides both a short-term and long-term protection, improving healthcare in a systemic way which will not only improve life chances of BAME communities in both COVID recovery, feeling accepted, and providing the foundations for a more adequate protection should COVID worsen again. Health influences all elements of an individual's life. Poor health equates a poor quality of life. Therefore, I endure this policy as crucial. Here is my bibliography for all references cited. Thank you for listening, Minister.